Welcome back, everyone. Sorry for the delay. I hope you've been enjoying the jazz and your virtual lunch. I hope it wasn't that virtual. You had a chance to actually eat something. For us, it's mid-afternoon here in New York. And there's Katti. So I think we'll move right on to our next session, which is going to be, we've talked a bit about it, and we've touched on the subject in our last webinar last week on corrections and the impact of correctional healthcare, the impact of the pandemic, rather, on correctional healthcare. We've got another great lineup of panelists and a great moderator. You all know Katti, who is the journalism coordinator for the Justice in the Southwest webinar series. She's a contributing editor for the Crime Report. She's a Pulitzer Prize winner. And in addition to her active writing, she actually runs New York University's Urban Journalism Workshop. I don't know how she fits it all in, but Katti, over to you.
You know, I hustle hard, Steve. Thank you so much. Andy Potter, Dr. Alvarez, Dr. Dolovich, thank you so much for being here. Y'all can read their extended bios in the program, the material sent to you. But briefly, Dr. Alvarez is Chief Medical Officer for NaphCare Correctional Healthcare. He's the former medical director at the Maricopa County Jail. Sharon Dolovich is Director of the Prison Law and Policy Project at UCLA, and she launched its COVID-19 Behind Bars Data Project. Andy Potter is a former corrections officer, executive director of the Michigan Corrections Organization and founder of One Voice United. Just for the record, I cover both healthcare and criminal justice and the intersection of both things. And to the journalist here, there's a bevy of stories on the healthcare front that we tend to ignore when it comes to criminal justice. So we are immediately talking about COVID and the overlay of COVID on correctional healthcare, on correctional health professionals. But there's a whole backstory to that in this moment, an aging prison population, public health concerns tied to the fact that most people leave prison and jails, and many have entered jail with a whole litany of pre-existing illnesses. So there's the compassionate release thing. So this panel is gonna talk about COVID, but also the backdrop, sort of conditions pre-COVID and what we're projecting for the future. And Dr. Dolovich, I'm gonna call you that now, and then I'm gonna dispense with all the honorifics. But if you would start us off.
I'd be happy to. Thank you for having me. So as Katti said, I'm on the faculty at UCLA Law School. I've actually been teaching there for 2 decades. My focus is on prisons and prison law from a typically law policy theory kind of angle. The data stuff is new to me. But at the beginning of the pandemic, I kind of accidentally launched a data project, and it has grown considerably. And so we have become kind of one of the main sites around the country that is tracking what's happening with COVID behind bars. And so what I'm going to do is, at the end of my remarks, I'm going to just show you the resources that we have available to you and give you a little bit of a tour so you can see what we have and how to make use of it. Basically, the main thing that we do is we aggregate all the facility level data in terms of taking from DOC dashboards, jail dashboards, infection rates and testing and deaths related to COVID in custody. We track all the prison systems, whatever jail systems are providing data, and also immigration detention and youth detention, among other things. We're also tracking vaccines, and I'll show you on the website where you can get our data on vaccines. So that's kind of like just generally speaking. We also have we have 4 data scientists who are working on putting together data sets. So if any of you is a data journalist and wants to use our data and would like help kind of making sense of what we have, we're kind of one of our policies that we're always available to journalists. So if you have questions about the data or anything you'd like to ask, we can help you. What I thought I would do is I have a list in no particular order, just of issues I wanted to flag, just so you can sort of get a feel for the kinds of things that are happening, what's new, what's important, and what is worth covering. And then, as I said, I'm going to give you a little tour of our online resources. Okay, as I said, this is in no particular order. So one thing that we are finding is there is a really massive problem, as you might imagine, with data transparency. So we're trying to figure out what's happening in the facilities, who's got COVID, who's getting tested, who's dying of COVID. And it's very patchy and very insufficient in terms of the data that's available. So two things about that. One is we have a data scorecard that we just launched, and I think there are a lot of stories buried in there. So we have a methodology, we have grades, we have the raw data on the website, and we've also given a letter grade to each agency to try to rate on how they're doing on data transparency and data quality. And just kind of spoiler alert, out of the 53 agencies we graded, we had 41 who failed. So again, there's a lot to discover about what is inadequate in terms of data presentation in the prison systems around the country. And then the other kind of sleeper issue here is the fact that we're not even grading jails, because of the 3,200 county and local jails that exist in the country, only a small number are actually posting their data. So one of the really troubling things that's going on in this current moment is we actually know very, very little about the spread of the virus in jail facilities. And I'm talking about the impact on people who come into the jail as detainees, on people who work in the jails, and also in the community, because there's a lot of churn between jails. People are constantly coming in and going out. And so we actually need to know much more than we do. So that's a big issue. So second thing I wanted to talk about, and I said I was just going to kind of briefly give an overview, is about institutional culture and the attitudes of correctional administrators in particular around the information about what's happening inside, not just the data, but also just the experience that people are having while they're in custody. One of the things that we have noticed from the beginning of this pandemic is, and this is not new, by the way, a lot of this is not new, it's just that it's come to the fore during COVID. One of the things we've noticed is a kind of proprietary attitude among corrections administrators, jails, prisons, ICE detention, et cetera, as if what is happening in their facilities is their own personal information, and they have a right to decide how much to share it. Now, it's true that the Supreme Court has given prison administrators and jail administrators a lot of authority to decide who gets into their facilities. I actually think that it's totally wrong-headed, but I think that culture of secrecy has festered so that now when we have a really urgent public interest, we always have had an urgent public interest in finding out what's happening in these facilities. Now it's especially so. And so I think there's a lot there to be uncovered about the attitudes and the reason why there's so much secrecy. Point number 3 has to do with the impact, especially on juveniles and people with mental illness over the last year. So those of you who know anything about long-term solitary confinement, you would know that, first of all, the data is clear that long-term solitary confinement and isolation compromises people's mental and physical health in really extreme ways. And it's so dangerous and devastating that there have been many legislative and court interventions to tell corrections agencies that there are certain categories of people they cannot hold in long-term solitary confinement, including juveniles and the mentally ill and pregnant women, just to take 3. But actually what we've had over the last year is effectively long-term solitary confinement, because facilities have been locked down with no programming, no visits, minimal movement for the last year. And that includes juveniles and people with mental illness, and not to mention, and of course, pregnant women too, and everybody else. So I think that here, I've seen almost no reporting on the impact of this kind of long-term lockdown on these groups in particular. And I think this is something that's going to come out once the pandemic has run its course. And I would love to see journalists getting ahead of it to try to figure out precisely what's happening and how people are experiencing these conditions. And that actually relates to another thing I wanted to mention, which has to do with the mental health impact. So we have been focused, as most people, on the physical impact of the virus on particularly the vulnerable people in prison who are getting it and dying of it in higher numbers. But there is a mental health crisis underlying all of this because, as I said, people with mental illness are being held under such oppressive circumstances, understandably, right? Their response to trying to stem the spread of the virus. But meanwhile, there are real costs here. And so one of the things we've been saying at the Data Project is that we suspect there are increases in suicide rates, and we're going to see more of that once the data comes out. And I'm worried about things like self-harm and other kinds of the impact of untreated mental illness. So I think that there's tons of investigative work to be done there. Another feature has to do, and this is again in no particular order, but another thing that is going to come out over the, as we come out of the urgent phase of this pandemic and into the making sense of what's happened, is going to be trying to figure out what the mortality impact has been, and in particular, how many excess deaths there will have been over the course of the pandemic as a result of COVID. And here I can kind of give you a scoop, because we have actually just posted in the last 20 minutes a paper on the Lancet site that has to do, I can't tell you the details, but it has to do with excess mortality and life expectancy impact on people in prison in Florida. In particular, we focused on Florida because that's where we had the data over the 9 months of the pandemic. And it apparently will be in a preprint available for you to download in the next 24 to 48 hours. And the data there is eye-popping. So again, I can't tell you what it is, but you will see it for yourselves. And that's why I encourage you to take a look. Katti mentioned compassionate release. Another thing we're studying at the Data Project is basically the failed mechanism of compassionate release during this period. And I think there is a lot to be written there about why compassionate release doesn't work at the best of times, and why it particularly hasn't worked now. And what it tells us a few things. It tells us we need a more meaningful system for decarceration during exigencies, and it doesn't have to be a pandemic, right? There's fire, New Orleans during Katrina, Oregon during the forest fires. There are going to be moments where we have to decarcerate quickly, and we have no mechanisms. And in this case, compassionate release, which focuses on elderly incarcerated people, is supposed to have been that mechanism, but it has failed. It has failed completely. And relatedly, there is a problem, obviously, with the fact that we have been unable politically to release the most vulnerable people in custody. The most vulnerable people in custody from COVID are people who are elderly and or medically compromised. Unfortunately, those are the people who have likely committed the most serious crimes. That's why they've been there for so long and been allowed to get, reach the point that they're in. And I think there's some real investigative work to be done to kind of triangulate who is most at risk, who has the most serious crimes, and the recidivism data, which basically tells us that this population is very low public safety risk. And then there's a story to be figured out about why in each jurisdiction people haven't been released. Katti, I should ask you, I can just keep going, but you should tell me how much, do I have any more time?
How about another minute, and then we're going to move to Dr.
Okay, then you know what I'm going to do? I could go on, but let me just take my minute. Can I share my screen?
Sure.
Yeah, okay. So I'm going to take you to our data page, and hang on. Let me just find my, where is our data page? Oh, shoot. All right, well, I'm having difficulty finding my gun. I wanted to show you where we are, but I will just tell you basically what you find. If you go to @UCLA or UCLA COVIDbehindbars.org, you will find all the vaccine data that we have available. Right now, we're tracking 18 sites. You'll find a main map that has facility level data for federal facilities, state facilities, ICE, and juvenile detention. You can go to each state page and get granular detail for each state. I really recommend that you follow us so you can get to our blog, because we are pushing every day, and also on Twitter @UCLA Prison Data. Every day we're pushing visualizations and findings from the massive set of data that we have, and so you could kind of get a jump there. And if you go to our main Google data sheet, and I'll drop these in the chat when I'm finished, you can find the aggregate numbers on testing, infection rates, and deaths for staff and prison residents. You can find facility level data. We're tracking about 1,700 facilities. You can get data on jail and prison releases, on grassroots organizing, on immigration detention, on juvenile detention. And as I said, bring us your questions about the data. We'll be happy to answer them. Sorry to go on.
No, thank you so much. I'm throwing resources in the chat for reporters as we go. I put the National Commission on Correctional Healthcare, which is a great resource, which has all kinds of conferences, etc. Dr. Alvarez, please.
Hi, everyone. I'll kind of try to just jump off of some of Sharon's points and go from there. I don't have anything large that's prepared to discuss. The biggest thing I think we as NaphCare, we have about 34 facilities in 14, 15 states right now, all jails at this point in time. So as Sharon was mentioning, a lot of the data from jails is lacking. Part of that, I think a large part, is the high turnover in the jail population and the different ways that all the counties have to deal with COVID, as far as like for the sake of getting testing numbers. Some of the facilities, NaphCare, my company, will provide the samples and the test kits to to test people. Others, it's the local public health department or other hospital agencies or other partners in that community that are doing the testing. So all that ends up being put into the county. So the county has the numbers, but it maybe doesn't reflect just the jails numbers, which make it really hard to track in a way. So from us as a company, we can kind of show different data from what we have, but I can only pull the numbers out of our electronic health record for the tests that I've completed. The ones that are done by the public health that are coming in won't be showing most often in my data, but it will be in the county's data. The other part that I think is difficult in a jail is that you're dealing with much different size population than most of the prisons. And as Sharon mentioned earlier too, the jails have done, most of our facilities have done a good job of trying to get people out and reduce their populations. So all of our sites significantly reduced their population. But now they've slowly, over the last years, the courts have opened up, started to kind of increase their population sizes again to where some of them are at the same level they were from before COVID. Part of that has to do with that there's so many agencies involved with trying to get that done as far as getting the population down. I think all of the sheriffs that have discussed as our community partners have wanted to decrease the population. The problem is also getting the courts and the arresting agencies and all of them together. So as Sharon mentioned, it's difficult to coordinate, and whether you have this plan already in place, set ahead of time, makes a lot of sense in trying to get those partners together to all decide, how do you do this? How do you get people out? The other is, how do you get the most at-risk people out? What we've seen is the populations have decreased in the jails, but what's left is the sicker, probably most vulnerable population, because the people with the low-level offenders are being churned out. Even before COVID, there was a lot of work trying to get jail populations down by having, citing and releasing people, not, putting so many people with low-level offenses or first offenses into jail to begin with. But now what you're seeing is this sicker population who's left because they've had multiple offenses, and unfortunately, a lot of them are mental health related because they've come in and out with a mental health diagnosis that has been untreated maybe in the community or falling off of their medications, and they're involved with the justice system multiple times over and over to where they hold higher levels of classification and they're staying. And again, so that's the sicker population that's left in the jails for us to try to treat. So we're kind of balancing all that out. The other part that's been confusing is dealing with so many counties. Many of the states, it's like every city is its own county almost. So there's a large number that you're trying to deal with. So it's difficult for me with just 34 that I'm having to deal with across the country and seeing everybody's doing it a little differently. Not just every state level, but every county as well, whether the county has gotten from the state, the material for the testing or the material for the vaccines, all of it is coming again from those community partners, and they all have different rules. From the vaccine standpoint right now, it's been very difficult. I have some sites in the East that they made the correctional population a priority 1, which meant they were going to vaccinate right away in that first group of people. The large majority of the other sites are just barely getting to that level of allowing the vaccine to be available to us to even give to the jail population, besides the people who are already in those priority levels, like those over 60 years old or those with the chronic conditions. So all of that is just a lot of different things that we have to kind of deal with to try to make sure that we can get those to the populations that again is most at risk, but it's very difficult dealing with so many different agencies. But again, go ahead. No,
you go on, Jeff. I'm sorry.
No, I was just going to say that, I think the biggest thing I look at when I'm trying to discuss is trying to kind of go with my staff and tell them, look, this is a worldwide pandemic. This is not something that the United States solely alone has failed. We've kind of failed as a world at trying to anticipate. We all kind of knew it from a healthcare standpoint. Something like this was coming. I mean, there was warnings all the time. It's just none of us really prepared for it because everybody put it on the lower priority. It was public health systems around the country are the least funded county department probably for any department in the county. So they're always the ones who are looking, they're sustained by just grant funding and other things. They have very little dedicated funds. So a lot of this was just the preparation, again, across the world and trying to deal with it. And the best we can do is try to move along.
Dr. Alvarez, before we, Jeff, before we move to Mr. Potter, before we move to Andy, would you remind us, I know your company is based in Birmingham, and how many states do you work? I know you work in Arizona, but is that the only place in the Southwest where you work?
Sure. No. So we have, I think 14 states now, because this is the time of year where we pick up new sites depending on contracts with different RFPs that are put out by counties. But for the West, we have 9 sites in Washington State. 8 of them are county, and 1 is a city jurisdiction with multiple cities who've kind of contracted together for a detention facility. Have 2 in California, 2 in Colorado, 1, 2, 3, 4 in Nevada. And in Arizona, actually, the contract isn't a comprehensive contract that NaphCare has. It's a TechCare only, our electronic health record. A lot of large jail systems in the Southwest use the TechCare's electronic health record, but not necessarily contract with NaphCare for comprehensive services. For example, Orange County, Riverside County, San Diego, San Bernardino, and Maricopa all use that TechCare electronic health record.
Thank you. Andy, it's good to see you again. Take it away.
Thanks. I appreciate you having me. I always enjoy this. It's interesting, and I like to hear the perspectives on all sides. My perspective really comes from the side of a corrections officer. I'm the founder of One Voice United, and I've also spent over 30 years working inside and around prisons, and I've seen a lot of pain and trauma experienced by everybody that's touched by the criminal justice system. It's really a system that was never designed for success for anyone on any given day. And I'm also too familiar with the challenges that come from performing this job with all the negative impacts that result. And, you know, some of the circles that I travel in, we talk a lot about what this job brings: PTSD, alcohol dependency, a shortened life expectancy. But I'll say that this past year, by far, has been the darkest in the history of our profession for a lot of reasons and for a lot of people. And if you take any given average year, 11 corrections officers lose their lives in the line of duty. But in the past 12 months, we've lost over 160 officers and 40 non-custody corrections employees to COVID-19. I would say the essential corrections officers and employees that work in the most dangerous environments for exposure to infectious disease, COVID-19 has multiplied those dangers several-fold. And those tragic stories really went mostly untold. You know why most Americans were urged to socially distance and to self-isolate over the past 12 months. Corrections staff have not been able to do that. They go in every single day and they try to do the best work they can in some conditions that, without saying, are extremely difficult. Now, I could go on and I could tell you a lot of stories and a lot of experiences. I've had staff call me up at 3 a.m. that have contracted COVID, that can barely breathe, that are scared to death for their life and for their families' lives. And I've had them come out of work and call me and say, this is something unlike anything I've ever encountered. It's like a medical ward in some of these prisons. And that goes untold in many instances. Almost half of the corrections officers in Michigan have contracted COVID from the beginning of this until now. And we're not even having the conversation yet about those long haulers and what they're going to have to deal with inside, those who are incarcerated and those who work there for many years to come. This is going to be a growing issue and a growing conversation. Hopefully that we can pick that up again later on as well. I just want to share some statistics, in the spring in an effort to hear more directly from those officers' experiences and concerns. We did a One Voice United fielded an online survey completed by over 1,200 correctional staff across the country. The vast majority in these surveys doubted the readiness of the facility to handle a pandemic. 65% said their facility was not at all equipped. 27 said somewhat equipped. The top three concerns really expressed by line staff were the protective testing, the poor communication, contributing to stress and distrust inside, along with the uncertainty of everything, the lack of protective gear, such as gloves and masks. Even to this day, we're struggling with that. 53% surveyed said that many felt extremely at risk because of the lack of testing or by that poor communication. There's a level of distrust that we can get into later, hopefully in the question and answer, but 61% reported not having any of the tools they need to do their job, and 67% reported that neither they, the other staff, or their union had been involved in any developing of any protocols or procedures related to COVID-19, which really talks about another issue. But I'm going to pause, but I would like to do this before we go to this short video that I want folks to see. I want to put a little bit of a spotlight on the stories of officers going above and beyond the call of duty. There's been blogs and others, but I just read a blog posted of someone who was incarcerated who highlighted 2 corrections officers who helped save his life and many others. Just today, I had a conversation with a corrections officer who her and her partner worked shoulder to shoulder with folks that are incarcerated, trying to take care of people in a way they've never would have thought. And that is really, I think there's glimmers of real humanity there. And those are stories worth telling and lifting up and not forgetting about. So I think there's a lot of urgencies even today. COVID has been like a brush fire from day one. It's just traveled through this system around the United States and in other countries too. We forecasted this was going to be a problem, but it's undeniable that the Department of Corrections were utterly unprepared for this pandemic. And I feel like they still are lacking any real public health preparedness plan for the next spike or the next horrific threat that we've talked about already. There's something else around the corner, and there's still no plan for any of that I know of. So I'm going to stop here, and we can play a short video, and then we can get into the questions and answers if that's okay. And I think Chris is going to play the video.
Neighborhood projects have been happening across the country, and the conversations we've been having feel more relevant and more meaningful than ever before. And few groups have a more important yet untold story than the often overlooked men and women who do one of America's toughest jobs, corrections officers.
Corrections is a profession that most people don't understand until you're one of us.
I was told when I first started, in the public eye, you're always the villain, you're never the hero.
It's not Shawshank Redemption.
We all are human, and we all have families.
Without a doubt, there is no other profession in the world right now that is in a crisis situation as much as we are, with the exception of the healthcare providers. We are on the front lines. We are the first responders.
It all started with a riot a week ago, and it's been going downhill from there.
The virus invades the institution, and then they're running around trying to put out these little fires by stomping on them. But from our experience, the bad part is once it's into the institution, it's too late. It's like a brush fire. It starts at one side of the facility, and until it runs out of human beings, it continues to burn through your population.
There's 688 total inmates, 286 tested positive.
About 900 officers that's out quarantined or tested positive.
We have 479 inmates that have tested positive. As of yesterday, we lost our 21st inmate.
We're not used to this kind of threat. We're really prepared to die at the hands of an inmate, but not a microorganism.
20% of the officers don't even have face masks. 25% of the officers don't have hand sanitizer. We're in the middle of an epidemic and 14 of us are dead.
We've got officers who said, look, this isn't even like a prison anymore. It's so bad. Broke down and said, look, I'm really struggling. I mean, he's living in his driveway in a camper. His daughter has one lung, and he's scared to death that he's going to bring something to his daughter.
Some of our staff have gotten to the point of where we don't call ourselves essential, we call ourselves sacrificial. We lost our first employee yesterday. She was a 37-year-old young lady, and she died in the line of duty. You go from being shattered to angry, and you just, how do you explain that to her father?
It's a reality check for all of us. I've lost members, and others on this call have lost members. I'd like to take a moment of silence.
Gosh, I hope we don't lose anybody. I'm with you guys, and whatever I can do for you from Colorado, let me know.
We used to shake hands and hug each other coming in and out to say hi, and we can't do that now. I miss the camaraderie where we can embrace each other, because we need that. And that simple handshake or that simple hug on your way in and out, sometimes that's all we got to get us through to the next day.
Part of the challenge for people in corrections is that you're so well trained not to show vulnerability. If you were gonna, for a second, let down the guard of we got this, what would be the truth that you would want to tell?
We're dedicated to what we do. We refuse to walk out of work or not come to work because we have our communities to protect. And that's what keeps us going back to work each and every day.
I've never been more proud in my position in the past 6 years as I've been in the last month.
We do deserve to go home and be able to see our families and take care of our families like everyone else.
Folks want to get back to normal, but I'm just saying normal for us wasn't good enough then. So I don't want to go back to normal after this.
If nothing else comes from this, I'm hopeful that there'll be a breath of unity across the country for all of us. And something like that, the idea of a neighborhood, that's what we are. We are a community.
Thank you for that, Andy. I actually want to start with you with a question. We have questions in the queue, but I want to start with some of the questions. What has been your organization's conversation, if you will, if at all, with departments of correction officials about what COVID has amplified regarding the health physically and mentally of your own workforce, and what might be changed in going forward?
In many forums, we have amplified the need for communication, better communication between the administration and the line staff, and better communication for those who are incarcerated, because that's where a lot of distrust starts. It's already an environment where folks are very leery and very suspicious of everything. And we've tried to make that well known that the health and wellness of those who live in prison and those who have to walk in there every day and work. And the tensions between those folks are growing because in some ways, when that communication has to be relayed just by line staff, that's who's always bringing the bad news. And that's not always consistent, and that's not always accurate. And that leads to a lot of distrust and stress. So that we have been bringing up over and over again. And hopefully the involvement, bringing everybody to a table and saying, look, we're as Jeffrey said, this was a worldwide pandemic. This is nothing to take lightly. This isn't just change a policy here and there. We had to change everything about how people live in these small communities. You can imagine the gravity of upheaving someone's life and how they have to live each day. So that just leads to a lot of tension.
And the second part of my question, well, my second question is twofold. One, there has been some coverage on corrections officers who have been unwilling, or at least who previously were unwilling to take the vaccine. More and more people across the spectrum are buying into the vaccine now. How has your organization tracked that? What do you see changing? And secondly, how do journalists who typically have a really hard time getting interviews with corrections officers, how do you suggest folks go about that?
So I will speak on behalf of One Voice because that's a national organization, and we talk to corrections officers all over the United States. I can tell you that a growing number of folks that work in prison, not just corrections officers, but line people, everybody that works in there, it's a growing understanding that folks are going to get vaccinated. They want to get vaccinated. There has been some resistance in some ways, and I believe a lot of that has to do with the miscommunication and the distrust that not only that the Department of Corrections felt, but the country felt. There's other professions as well, even healthcare, that are really resistive or have bought into a notion, right? And it's just about educating people and really working with them and bringing that information from a healthcare perspective into those institutions and educating people, talking to them, communicating with them. So that's the one part about and that's a personal choice, and it's nothing to take lightly anyway. So that's that part. I believe that's a narrative, though, that's been playing out since day one. I have read many times how corrections officers won't wear a mask. They're the ones that are bringing COVID into the prisons. And some of this is true, right? We can't deny that. That's accurate. What I don't like is the narrative that plays out in the media that doesn't go deep enough and doesn't go far enough, right, to really understand why that is. And why is it so prevalent in healthcare? I think there's another story to be told with that. So I don't like how that narrative is set. And I'm sorry, Kate, what was the other part of your question?
How suggestions for journalists who want to include, rank and file corrections officers in their stories?
And that's always a challenge. Even in Michigan, anytime a corrections officer speaks to the media, they run a risk of discipline, and they run a risk of speaking without speaking about a policy or something, and they can get disciplined or fired even. Even talking to a state legislator can cause them to be disciplined, believe it or not. And that's not, that reverberates. That's a chill. When someone gets in trouble, that goes down the entire spine of corrections. And we really should want it to be much more transparent. We should really want folks to be able to talk to the media, to the legislature, and to explain what's going on. But that's not the case. And not just in Michigan. That's not the case in a lot of states.
Thank you. Jeff, and perhaps Sharon, this question also is for you. Given this knowledge that we likely will have another pandemic or whatever you will call it, what What are the innovations? What is changing? Is there discussion anywhere, particularly in the Southwest, but elsewhere, about changing the very construct of prisons and jails so that you can social distance and do those things?
Sure. I can start with just the measures that we see. I mean, I've tried to tell my own family, look at what's happened to flu season this year. We pretty much eliminated it by mask use, social distancing, and washing our hands. So these things that we've done in the community, to just putting shields for cash registers at grocery stores, things like that. Those are things that should have happened a long time ago, and will continue. In the jail, we see some of the things that I think that might continue: isolation or quarantine of new intakes into jails. Instead of mixing new people into a general population and letting them kind of go and cohort as a group for 7 to 14 days to make sure that they're stabilized and then move to the general population. I see a lot of jails continuing that even after this, because it was a good way to identify not just COVID, but other maybe infectious diseases or uncontrolled acute and chronic diseases, along with those people who many times are suicidal when they first come into a facility. That change of environment. And so having this place where you can monitor people in an intake area for at least a week, 2 weeks max, that's a good thing, especially if we can not solo cell or isolate them, but keep them in a group together in a cohort. That's actually much better, and what we've seen most of our facilities try to do is isolate like that. That's one thing I think we could see going on.
So I'll just jump in. I agree with Dr. Alvarez that if there are good practices, we should continue them. But I think it's actually a fantasy to think that we can continue to incarcerate on the scale that we are incarcerating now and actually be in a position to respond to the next emergency, whether it's a viral pandemic or otherwise. When you're crowded into dorms, you can't social distance. And it's not as if, I think people have this notion that, well, we'll quarantine people when they come in, and then once they come in, there'll be no movement. And so there's no way for the virus to get in. But actually, that's not how prisons work, right? So staff come in every single day and leave every single day. Incarcerated people, like detainees, come in every day, and other people leave every single day. And the other thing is that you have to have people circulating through the facility multiple times a day. You have to bring people, if you have most people who are stationary, you have to bring them their food, you have to bring their meds, you have to bring them mental health care, to the extent that you're able to do that during a lockdown. So the fact of the matter is there's literally no way to continue incarcerating in the form and on the scale that we are currently doing and hope to be able to tackle this again. I mean, what I hear from Andy is, I think, really important. It's a sea change in the way correctional staff are thinking about their job and their role and the enterprise of incarceration. And, I think he'll agree with me that we had deep problems on all sides well before the pandemic. This has just exposed the unsustainability of what we've been doing.
Thank you. This question is from Chandra Whitfield. What has the coronavirus pandemic taught us collectively in terms of preventive, and you may have answered part of this, but perhaps we can dig further, in terms of preventive and proactive measures that we can and should be taking from a public health standpoint in the American prison system? What changes do you hope for system-wide? And that's for anyone who wants to venture.
I mean, I think I was just speaking to some of that. I'll just say a couple of other things. One is, I think the number one thing that I haven't already mentioned is we have to reorient our thinking around what prison does and is. It's actually a public good if we've decided we want to pay for prison. That's something we're investing in as a society, and we need to be better about our investment. And right now, our typical way of approaching things is to think about it purely from a narrow, individualistic public safety perspective. So this individual, what crime do they commit? Are they likely to do it again? Who's the individual victim they're likely to victimize when they get out? And the fact is that is public safety in that order is a very tiny slice of a public health oriented strategy. So public safety is part of public health, but it's not the only thing. And what I'm hoping will come out of this is a recognition that prisons are not isolated institutions. They are in our societies, and we're supposedly running them because they do us some good as a society. So what I hope will happen is that we'll have a broader perspective, a more public health oriented perspective that will recognize all of the many ways, not just during the pandemic, but in general. Andy talked about impact on correctional staff. There's a huge impact on family members of people who are in custody. communities who lose people who are in custody, political contribute. I mean, there's all kinds of things we lose because people are isolated from the community and we're doing it too much. So I hope that we'll have this will be a catalyst for a dramatic rethinking.
Andy?
Yeah, I would agree with almost everything that Sharon said. I mean, think about the physical plants and the conditions that people live in on a day-to-day basis, and the amount of disease that travels through a prison on any given time because of that close proximity. She touched on the housing condition itself, right? We have 8 people living in a cubicle that was designed for 4, and you can't possibly be in that kind of an environment. And 2 things: you can't be in that environment and do any kind of rehabilitation on any level whatsoever, number one. And you certainly can't do that during a pandemic and feel safe about it. So the health and wellness and the way the conditions are inside the current system, a system that wasn't designed for success for anybody since day one. We have a lot of prisons that are just closed and it's called a success through reform, but then all of those folks are piled into another prison and have to live in kinds of situations and conditions that were not built. So the physical plant is a big deal. The ventilation systems, and I could go on and on and on, but I would say this, I would say that there has to be an overall health preparedness plan that's a national plan for the Department of Corrections. This has just peeled back a couple of layers and exposed things that we've known about this system for a long time.
Before I move to your question, Felicia, I see you. Jeff, I just wanted to ask you some questions about or whether what's gone on with COVID, early releases where you've had them in the places where you are contracted. What's changed in healthcare? What has this been a moment of refining, say, discharge planning in jurisdictions that do discharge planning? Because some see this moment and perhaps the overlay of Obamacare as an opportunity to get formerly incarcerated folks into the healthcare system. So what has COVID done to either make that better or not?
Well, I think for the better is just the reduced population has allowed us to have more staff time with some of the patients. The unfortunate problem is, though, because we're isolating them and trying to keep them from moving, it hasn't really increased the access to care that you would assume. Like most of the jails at this point are saying, well, do we really even need this much staff? And I'm like, okay, that's not the way to go. I mean, okay, you have a pandemic, which has increased the number of things that we have to do, but yet the counties are seeing it because of, again, decreased funds from the cities or the other arresting agencies for housing and for other things. Their budgets are going down in some ways, and then they look at, okay, well, should we cut staff? Should we cut different things? So again, all those things that you were saying, whether we're kind of more focused towards more rehab, more MAP programming, more even funding for STD screenings and vaccinations, and these are things that, from a public health standpoint, we should be doing in jails and prisons all the time. So I think the big answer to this is funding. Right now, they have the funding in some ways to do some of these things, but will it continue? And as Sharon mentioned earlier, a lot of this is really how we view it. Are we going to build these systems in the jails and prisons, or do we build them in the communities? I'd always say build them in the communities, but it doesn't seem to fit what is quote unquote our American philosophy of incarcerating people. So if we're going to do that, then we need to build better jails and prisons that can accommodate for those items. Again, MAP programming, huge at this point in time with our opioid crisis and things like that.
Break that down for people who don't understand the acronym. Break that down.
Sure. Medication assisted therapy for opioid treatment. Right before all this, we kind of just forgot all about that. We're in the middle of an opioid crisis. And so, yeah, it's amazing how everything has shifted. I've had to refocus my own staff and saying, okay, people, we can't miss that still the common things are common. People are coming in suicidal. People are coming in with uncontrolled mental health disorders. People are coming in with uncontrolled diabetes or even undiagnosed diabetes and hypertension and all these other problems. And we're worried about giving them a vaccine shot. I want to give that vaccine shot, but I don't want to miss the person who's dying of diabetes, is suicidal, and all these other issues that is our real focus every day as we're focusing on people coming into the jail.
So this question is for Tim Igo. He asked, are we seeing significantly different COVID outcomes in state-run versus private prisons, or is there too little data to say?
I just have to jump in here on this. Is something that we've been working on, and I can tell you that it's a more complicated data analysis question than I thought, but stay tuned because I've been pushing my team on this and we finally have somebody focusing on it. So if you get in touch with me like in a month, I may have data for you on that question. And by the way, same thing with the gender. We're also working on the gender disparity between men's and women's facilities. And that also has turned out to be a complicated enterprise, but I also hope to have data on that in the next month.
And this question is from Felicia Fonseca. It is, how does the jail make up for the lack of staff? And what are some of the ways that inmates have responded? And that's a workforce question that's broader. And because my question to you, Andy, is what are the trends? What have been the trends in correctional workforce, and how has COVID altered that trend? You're still muted, Andy.
Can you just rephrase the question for me, Katie?
So that's fine. Felicia's question was how, given that officers have had to quarantine and been out of work and died, frankly, how does the jail make up for the lack of staff, and what are the ways in which inmates have responded to lack of staff? And then more broadly, what have been the trends in correction officer hire, fires? Are there enough, et cetera?
So I would say that there, just even before COVID, it's very difficult. Staffing levels across the United States are at an all-time low, and bringing people into a profession that seems to be and has been devalued around the United States for some time now has been difficult. Retention, recruitment, always a problem, and it's even becoming a bigger problem now. We have had to rely on all kinds of people stepping in and helping out and filling in that don't have all the proper training. But we've tried to fill in where we could when corrections officers are sick and ill and been off work. And even some of the policies, although we want to be safe, we want to make sure people are safe, some of the policies have been really like draconian in some ways when it comes to if you are in any kind of proximity for any amount of time. This is the part of the miscommunication and misdirection in policy that I'm talking about. Then you have to go home for 14 days. And if you run out of sick time, then you're just not collecting a paycheck. Now, there's no incentive for somebody to come back into that after they've missed a couple of paychecks. And, you know, the amount of people that went without paychecks just on an assumption, and we're not taken care of, we're not looked out after, that's hurt the recruitment probably as much as anything. Yes, I would say. And the trend is, there used to be generations of people that would bring their family members into this because it's a middle class job in some ways and in some states, right? So that's an avenue. It's a path for them to get into the middle class for all walks of life. And now a lot of folks don't, there's a moral obligation not to let their family members and others come into a system that's so broken like this. You know, suicide rates, we haven't even talked about that with correction staff, which is huge. And this is going to exacerbate that.
Steve, I know you said it's time to end, but may I just ask Jeff one question, he'll give a fast answer, because clinician workforce that's always been an area of chronic shortage. You said y'all now feel like you sort of have enough people, but what are the challenges on that front? We had, I talked to one correctional health executive who said they gave bonuses for people to take jobs right now. Yeah, we've had to. So even though the numbers would seem to be better for us in the smaller populations, more of our staff for a smaller population, unfortunately, we're losing staff every day to even vaccination centers. So that, you know, there's this big push for healthcare workers, especially nursing, out in the community to give the vaccine. So we're having people resign to go work in these centers, and I don't blame them. They're offering a lot of money based on government funds, you know, that we don't have. But we have put in bonuses in different areas. We've, you know, gave shift differentials, other things, almost like a hazard pay in a way, whatever we can to try to keep. But I don't blame people for leaving for jobs on the outside that are more money and easier work. Thank you so much, Steve.
Yes, thank you all. This is a really absorbing conversation. I wish we had a little bit more time to get into it, but I want to thank each of you for taking the time. We're going to be going next from one crisis to a very different kind of crisis, our immigration and border issues. But first, we will take a 10-minute break. And again, thank you all for joining us.
Thank you, Andy, Sharon, and Jeff. See y'all next time. Thank you.
Thank you so much.
Bye-bye.